Now we are going to discuss about the session lateral chest view. Lateral chest view examines the lungs, bony thoracic cavity, mediastinum, and great vessels like aorta, like any other vessels. Indication: this orthogonal view to a frontal chest radiograph may be performed as an adjunct in cases where there is a diagnostic uncertainty. The lateral chest view can be particularly useful in assessing the retrosternal and retrocardial ARS spaces. If locating a specific pulmonary opacity within the chest cavity, it would be useful for requesting doctors to ensure that the side of the opacity is mentioned in the clinical note. This will allow a technologist to image with the side of interest against the image receptor, hence reducing any magnification from the increased SID, source to image receptor distance. Otherwise, a left lateral view is the default and preferred side as it demonstrated better anatomical detail of the heart. Patient position: standing upright. Next one is the left side of the thorax adjacent to the image receptor. Left shoulder placed firmly against the image receptor. Both arms raised above the head, preventing superimposition over the chest. Arms can be placed on the head or holding onto handle if available. Chin raised out of the image field. Mid-sagittal plane must be perpendicular. Perpendicular to the divergent beam. Therefore, using a paravertebral gutter technique, right side rotated 5 to 10 year anterior. So right side rotated 5 to 10 degree anterior. Technical factors: lateral projection. Second is suspended inspiration, means in this projection the breath hold in the inspiration. Centering point: the mid coronal plane of the level of the 7th thoracic vertebrae, approximately the inferior angle of the scapula. Collimation. The next one is collimation. Superiorly 5 cm above the shoulder joint to allow proper visualization of the upper airways. Next one is the inferior to the inferior border of the 12th rib. Anterior posterior of the level of the acromioclavicular joint. Next one is the orientation. The chest orientation should be in portrait. Detector size should be 14 by 17 inches. Exposure factor that is used in this view is the 60 to 70 kVp, or MAS should be the 12 to 30, 12, 10 to 20 MAS. SID, source to image receptor distance, should be 180 cm, and grid should be grid is used. Now we are going to discuss about these 2 points: image technical evaluation or practical points. So image technical evaluation: the entire lung field should be visible, superior from the apices, inferior to the posterior costophrenating angle. The chin should not be superimposing any structures. Second point is there is superimposition of the anterior ribs. Next one is the sternum is seen in profile. Next one is the superimposition of the posterior costophrenic recesses. A minimum of 10 posterior ribs are visualized above the diaphragm. The ribs and thoracic cage are seen only faintly over the heart. So the image technical evaluation should be the apices inferior to the posterior costophrenic angle, means CP angle visible. The entire lung field should be visible superior from the apices. Okay, inferior to the posterior CP angle, means visualize the upper the apices, uh, uh, upside the apices, and below till CP angle. The chin should not be superimposing any structures. There is superimposition of the anterior rib. The sternum is seen in profile. So sternum is clearly visualized in the lateral view. Superimposition of the posterior cost of training ribs. A minimum of 10 posterior ribs are visualized above the diaphragm. Okay. The ribs and thoracic cage are seen only faintly over the heart. Over the heart. The ribs and thoracic cage are seen only faintly over the heart. Okay, clear vascular marking of the lungs should be visible. So the next is the practical point. The same principle of the positioning can be applied to the patient in chair. Before exposing, ensure your patient is not leaning forward or backward too much. Okay, this will result in anatomy being cut off. Patients with a long-standing history of emphysema or COPD will have abnormally long lungs compared to the general population. Okay, so these things are remembered when collimating superior to inferior. Side marker placement is imperative. Patients can have congenital condition that mimic the image. Okay, so in this session we had discussed about the lateral view, just lateral view. Okay, so it is a good session. Just lateral view gives knowledge, gives the imaging of the sternum or the upside of the apices and below till CP angle. Okay, thank you. Namaste. I J.B. Gaurav Goel from the Faculty of Physiotherapy and Diagnostic FPD in Department of Diagnostic and Community Health in the discipline of Radiology from Vidyapeeth Women's University, Jaipur. Today we are going to discuss on the session uh, chest oblique view. Uh, chest oblique view. Okay, so AP oblique rib projection is performed to best demonstrate the axial ribs. Oblique ribs may be conducted either as an anterior oblique or posterior oblique view. Indications: AP oblique view especially focuses the on the axillary ribs. The ribs series is often considered to be an unnecessary, unjustified projections in many radiology departments. Indeed, the Royal College uh, uh, demonstration of a simple rib fracture does not usually alter management, but if a complication such as pneumothorax or infection is suspected, chest radiograph would be a proper appropriate view. Thus, if the projection might change the patient management, it may still be considered pursuant and working discussion. Means the chest oblique view is performed for for any type of refracture or pneumothorax or any infection suspect. Patient position. The patient may be erect or supine with their right RPO or left posterior LPO side closest to the image receptor. Closest to the image receptor. Affected side is rotated 45 degrees. Affected side is rotated 45 degrees towards the IR image receptor. The patient's arm closest to the receptor is raised and placed on their head, with the other on their hip. Technique is accept. AP oblique projection, respiration, suspended inspiration, centering point above diaphragm, level of T7. So the central ray should pass through the level of T7 located at the level of the sternal angle approximately 2 to 3 centimeter laterally toward the affected side. Collimation. Medially include 5 centimeter lateral to the sternoclavicular joint, SC joint of the unaffected side. Laterally to the lateral rib margin, superior inferiorly above diaphragm, 5 centimeter above sternoclavicular joint. Superior inferiorly below diaphragm, lower costal margin. Orientation. The chest oblique orientation should be the portrait detector size is 14 by 17 inches. Exposure factor is 75 to 85. Exposure factor for the evaluation of evaluation of the rib fracture or pneumothorax is for 60 to 70 kVp and MES should be 12 to 30 MES. SID, source to image receptor distance should be 100 centimeter. Grid, yes, grid is used in this projection. Image technical evaluation. Above diaphragm, first to 10th axillary rib of the affected side are demonstrated without superimposition of. Second point is thoracic vertebrae are included. Practical points. If adequate obliquity has been achieved, the glenohumeral joint on the affected side will be open. If you are confused by which way to oblique the patient depending on AP or PA position, remember that the spinous process will always point towards the unaffected side. For oblique, left oblique ribs, spinous process point to the right. Conducting AP rib oblique view produces less magnification of the ribs and provides more bony detail than that of the PA view. When a patient is unable to stand for an erect projection, have the patient supine and support by immobilization devices to adjust the patient into an oblique position. For the PA oblique projection, LAO or RAO, the affected side is rotated 45 degrees away from the IR with the C cassette as what the AP oblique. So in this projection, we discuss about the indications like refracture or pneumothorax or infection. It is purely it is a special view that is performed for refracture and type of pneumothorax or any type of infection in the lungs. So centrally should pass through the level of the T7 as any other view of chest. So in this session, we are after the studying this session or discussing this session, we are able to know about the positioning of the chest oblique view or the indications of the chest oblique view and how to find the rib fracture or and about the exposure factor that is used in the chest oblique view. Okay, thank you. The session is over. The session is powered by digital version 2.0, Jayoti Vidyapeeth Women's University. I think you are satisfied with this session. If you have any queries, then put it into the comment box. I will resolve it later. And also, also study your from your material and solve some, try to solve some questions. Okay, thank you related to this topic. Thank you.